Hello everyone and welcome. This is Michaela Conley, HP CareerNet and Health Promotion Live. Welcome Friday again, a beautiful Friday here in Columbia, Maryland. Hope it's beautiful where you are. In just a second I'm going to turn it over to Michael O'Donnell and Mari Ryan, who are going to talk about the burning question being, can we reduce our federal deficit and create jobs by making the healthy choice the easiest choice. Let me turn it over to Mari, who will make some opening remarks and the introductions.
Thank you, Michaela. This is Mari Ryan. I am the CEO of Advancing Wellness, a worksite health promotion company, but more importantly, a member of the Board of Directors of Health Promotion Advocates. On behalf of Health Promotion Advocates, I want to thank you all for attending today. Many of you may know about Health Promotion Advocates. We're a not-for-profit organization created to integrate health promotion concepts into the national U.S. policy agenda and all aspects of society. Most of you have known us mostly for our work leading up to the Affordable Care Act and the work prior to that with a number of bills that were proposed. The work that we're now focusing on and that we're going to talk about today is really more about that other little piece I mentioned, is the other aspects, all aspects of society part of the work that we do. This initiative that has been launched by the Board of Directors of Health Promotion Advocates is fundamentally to help create a healthier country, to make America healthy, our people and our economy. So the question that we're going to be addressing today is, can we reduce our federal deficit and create jobs by making the healthy choice the easiest choice? We believe we can. We believe it's possible to reduce the federal deficit by improving health. And our preliminary analysis, some of which we're going to go through here today, is going to help us understand just how that would work. So what we're going to be doing is Michael O'Donnell is going to be taking us through a presentation, and I'll be moderating as we go. Michael indicated that if you want to ask any questions along the way, just type those in the question box. And we're going to just address what kind of action needs to be taken to be able to reduce the deficit in our country, to be able to improve the national economy, and to be able to help create healthier people in our country. So with that, I'd like to introduce Michael O'Donnell. Many of you know Michael. He's the editor of the Health Promotion, the American Journal of Health Promotion. He's also a member of the Board of Directors of Health Promotion Advocates. So Michael, I'd like to welcome you and thank you for taking your time today to take us through this important material.
Well, thank you very much, Mari, and hello to everybody. I'd like to first explain the format. I'll start by talking about the Congressional Budget Office long-term budget projections, and then talk about the health-related costs of federal spending, then focus on our strategy to improve health, and then show you a little bit of the detailed analyses, just a little bit, and then talk about next steps. And I want to stress that this is really a work in progress. We really need your help in refining it. So starting with the long-term projections of the Congressional Budget Office. The Congressional Budget Office is a nonpartisan group that works with Congress to figure out spending and income from revenue from taxes for the federal government. And in this chart, it shows by year, the year 2000 through 2035, and it shows spending by the federal government as well as revenues as a percentage of GDP, gross domestic product. Now, this is from the 2011 long-term budget scenarios. It was released in June of last year. We probably will have a new report in this month, but this is the one that really caught people's attention. So this dark line that you see here is the spending, and it consists of, for example, Social Security is a big portion, Medicare and Medicaid is a big portion, plus CHIP, the Children's Health Insurance Plan, and then other non-spending. And you can see that spending is increasing over time, going from about 15% of total gross domestic product in 2000 up to a projected maybe 23, 24% in 2035. And you can see a big increase in Medicare, some increase in Social Security. Now, the dotted line is revenues from taxes. And we actually had a fabulous situation after President Clinton where we were collecting more in revenues than we were spending. The concern was of some people that we were collecting too much, so there were tax cuts. I'll get into that in more detail now. But the bottom line is we started collecting less than we were spending, and then that was exacerbated in recent years here. We spent a lot more than we collected. But it looks like in these projections, if all the laws on the books stay in place, maybe by 2016, our spending and our tax revenues will be about the same. This does not include the interest we pay on the debt. So it's not such a bad situation if all the current laws stay in place. But the alternative scenario projected by the CBO, and this is actually the more likely scenario based on political pressures, is that most importantly, the tax revenues will not increase, and they'll flatten out here. Revenues will increase a little bit more to 25% of GDP instead of maybe 24%. But the big problem is tax revenues will stay flat, and this will create a huge deficit. Now, what's the difference between these two projections? The extended baseline assumes that all current laws will continue. So the Bush-era tax cuts are scheduled to expire at the end of this year, 2012. Also, the payroll tax cuts, the emergency and unemployment benefits, all of those are scheduled to expire. So if nothing changes with the law, they will expire. Also, this assumes that federal spending in all areas except health care, Social Security, and interest will decline to historically low levels. The alternative scenario assumes that the Bush-era tax cuts will be extended and the Medicare payments to physicians will not decline. You've probably heard of the doc fix. The current law says that the reimbursements to physicians for Medicare are supposed to decrease by 30%. And this is supposed to happen, has supposed to happen every year. Never happens. They always come up with a fix at the end of the year. Also, this assumes, the alternative scenario assumes that the cost containment provisions of the Affordable Care Act will stop after 2021. And by the way, if the Affordable Care Act is either ruled unconstitutional or repealed, costs will go up even further. It also assumes that federal spending beyond health care, Social Security, and interest will still reach historically low levels, but not quite as low. So it gets worse. Oh, one other important point. You've heard of the financial cliff probably. If all these scheduled tax cuts go into effect, actually the increase of the taxes because the tax cuts expire, plus the sequestration, which is a mandatory 8% in cuts in defense and also some domestic discretionary spending, the concern is that this will produce recession. More specifically, we estimate that our growth of the economy next year will drop from about 3% of GDP to 0.2% of GDP. So the difference between these two scenarios is not just a difference of political perspective, left or right. It's really a concern that doing all these things might push us back into recession. So it gets worse in the long term. Under the extended baseline scenario, the big problem here is that Medicare and Medicaid spending skyrockets. Social Security also increases. Other spending doesn't increase. But still, if the taxes are raised as current law would allow, we do cover our costs. But if taxes are not raised and spending goes up a little higher, about 33% to from 30%, we create this huge deficit. So, and by the way, just to note, this is through 2085. The earlier chart was through 2035. So why is this all occurring? We have a breakdown for the 2035 data. You can see that Medicare, as a percent of GDP, increases from about 2% of total gross domestic product to 6%. And Medicaid and other health spending goes from about 2% to about 3%. Another big problem is that spending on Social Security goes from about 4% of GDP to about 6% of GDP by 2035. Now, the interesting other piece of this is the other spending has been historically ranged from about 14% to a low of about 8%, but for some reason they project that this spending will drop. It will drop based on the current laws, and even with some other pressure, it's expected to drop very significantly. I just wonder how realistic this spending drop is, given our history. So the big bad problem here is the debt. Under the extended baseline scenario, the debt as a percent of GDP, it's been historically around 25%, bumped up to about 50%. Recently, it actually dropped a little bit, but there's nothing we can do really to keep it from reaching about 75% of debt. And in the extended baseline scenario, it'll get to that level and stay basically flat. And we can survive. We can actually do well with that level of debt. The problem with, however, is the alternative fiscal scenario where the debt goes up to 200% of GDP by around 2035, and that's a big problem. In fact, we might not ever get to this point because it's unlikely that we borrow this money from countries like China. It's unlikely that they would loan us the money we need to get to that point. But if we do, I think it would be a crisis. I wonder if our economy could survive. Now, it's also important to recognize that the causes of the short-term debt and the long-term debt are really different. In the short term, the problem is not domestic discretionary spending. That's what you hear in the news a lot. And discretionary spending is health and human services, not including Medicare and Medicaid. So it's CDC, NIH, it's all the transportation budget, it's all the agriculture budget, it's all the judiciary, all the education budget, all HUD, Interior, EAP, NASA, basically all the stuff that you really think of government doing besides war and besides Medicare and Medicaid. Now, the historical range of this spending is only 3.2 to 5.2% of all federal spending. Last year, we were already well within that range. So our spending is actually not high compared to history. With the current laws that are in place, we're going to reach 3.2% by 2014, which is an historical low. And with the laws currently in place, we'll reach 2.8%, a new low. So discretionary spending is not the problem, regardless of what you hear from the pundits. Now, the causes of the debt, and by the way, we project this out to about 2019. The causes are the wars in Iraq and Afghanistan, which will cost about $2.3 trillion. Also, the Medicare drug program, which will cost by this time about $1.2 trillion. Now, these were spending programs that were put in place without any way to pay for them. Usually when we have a war or something else, we've either cut costs or we raise taxes to pay for them. We didn't do that this time. And then in addition, the stimulus, everything that was done between 2008 and this year is about $1.7 trillion. The Bush-era tax cuts have already cost about $3.2 trillion. If they're extended, this number should actually be 2020 instead of 2010. There'll be an additional $4.1 trillion. And then there was a baseline debt and other miscellaneous causes of $3.1 trillion. So just important to separate out the cause of the short-term and the long-term debt. They're really different. In the long term, and by the way, one other detail, to take a look at annual spending increases by president, this shows the percentage that each of the presidents increased their spending over the previous presidents. And this is based on the second year of the president being in office, because in the first year the president's in office, it was actually the previous president's budget that was passed. So the spending under the current president is actually the lowest in recent history. So the problem with the deficit is not, again, it's not these increases in spending, it's the wars, it's the tax cuts. So just to make that clear to everybody. Now, back to the long-term spending. The big problem here is that in this alternative fiscal scenario, by 2050, if we have an 18% tax revenue, that was historical revenue over the past 30 years. More recently, it's been higher. We were actually around 22% during the Clinton boom years, where we actually had a tax surplus. So, maybe 20% is more realistic. But if we go by the 18% historical average, by 2050, we'll be spending all of our revenues just to cover Medicare, Social Security, Medicaid. This doesn't even include spending on other areas. So certainly a significant problem. Now, how does that translate to each of us? Now we have about $30,000 per person in debt. It would grow to almost $280,000. It's just not a sustainable level. Now, this is really a crisis that will cause our nation's economy to implode. We wouldn't have national defense. We wouldn't pay Social Security and Medicare. Quite frankly, I don't know how we'd continue to exist as a nation. So, Mari, that's the basic introduction.
Well, Michael, this is really a fascinating analysis of a dire situation. Certainly, it's not easy. It's very complicated. But is there a solution? What does this have to do with health promotion?
Well, the reason that this is related to health promotion is really the huge size of the spending on Medicare and Medicaid, and also Social Security, regardless of the scenario. So let me look at that in a little bit more detail by talking about the health-related causes. So if we look at the health-related causes of Medicare costs, Medicaid costs, Medicare costs, Social Security costs, and low tax revenue, basically 4 health-related causes. First of all, lifestyle causes chronic disease, and we'll talk about this in more detail in a moment, which increases Medicare costs for each person. The more chronic diseases they have, the higher the cost for each person. Also, chronic diseases prevent people from working, so their tax revenues are lower. Taxes they pay to the federal government are lower. Medicaid costs for the people on Medicaid go up the more chronic diseases in place. So that's really the starting cause. The next cause is poverty and inequality. It causes lower tax revenue because people who aren't working aren't paying taxes. It also increases Medicaid costs because it puts more people on the Medicaid rolls. It also increases chronic diseases because of the difficult circumstances people are working under, which of course then increases costs. And it actually directly impacts lifestyle, which aggravates chronic diseases again. So aging society is also a problem. We have a higher percent who are going to be on the Medicare rolls. It lowers tax revenues because people retire and don't pay taxes. It also increases chronic diseases just because of aging. It increases Social Security costs because more people are on Social Security. The same thing with Medicare. As more people are on Medicare costs, it increases those costs. So very challenging situation. Now, we don't have time to go through the entire literature. I'm just going to pull out very quickly, talk about a few of the really important studies. This is from the NHANES data. It was just published in JAMA a couple months ago. And it looks at the risk factors in our nation from a positive perspective. Who doesn't smoke, who's physically active, who's at the recommended weight level, who has a nutritious diet. And you can see the percent of the population doing the right thing is somewhere between 1 in 5 and 3 out of 4. And these things lead to the different biometric values, and about half the population has the recommended levels. But if you look at how many people have 7 out of 7 positive risk factors, it's only about 1% of the nation, and only less than 10% do 2 out of 7. So that is the beginning standpoint from a health perspective. Now, what happens is, this is the list of the preliminary cause of death for 2010. It takes us a couple of years to actually figure out why people died. But out of the top 10, and these are responsible for about 75% of all deaths, these top 6, plus diabetes and suicide, lifestyle is the primary cause of these deaths. And for Alzheimer's and flu, it's a contributing factor. So 9 out of the top 10 cause of death have a lifestyle connection. 7 out of 10 is the primary cause. If you look at these chronic diseases, they account for all 75% of all spending. Chronic diseases cost 83% of Medicare spending and 96% of Medicaid spending. So what we're getting to is if we can improve lifestyle, reduce chronic diseases, maybe we can reduce cost. But let's look a little closer. Also, we have to recognize that income inequality causes not just poverty, but certainly poverty, but also the income inequality where people have different levels of income. We've got fascinating data that show, for example, these are a plot by states, and it shows that as income inequality increases, the whole index of health and social problems gets worse. Another big problem is the aging of society. Back in 2000, 1 out of 5 people, 20% of the population was 65. By 2035, it's going to be more than 1 out of 3. So, Mari, the crisis, this is the Chinese symbol for crisis, and it's 2 symbols. One is problem, and the other is opportunity. So I think we do have an opportunity here. And that's why we're asking the question, can we reduce our federal deficit and create jobs by making the healthy choice the easiest choice? Now, I'm going to go through some of what we know about workplace health promotion programs. You know, this field has been in place for about 3 decades, and our ability to measure the impact on costs has improved significantly. This is from a meta-analysis done by Catherine Baker and David Cutler and Dr. Song. David Cutler is probably the most prominent health economist in the world. They're all professors at Harvard. And they looked at a meta-analysis in which they took the data from existing studies and they basically pour all the data into a study and analyze it as a group. And what this does gives you advantage of a larger sample size. So with 22 studies in each of these areas on medical care costs, containment, and absenteeism, they found returns on investment of more than 3 to 1 for medical care costs and almost 3 to 1 for absenteeism. This is the type of findings we had found, not surprisingly, over the years, but it was great to have prominent health economists who are really dispassionate about health promotion find the same thing. More recently, Larry Chapman did a meta-evaluation, so he didn't pour all the data together. He looked at all the different studies. He found 62 studies. They didn't all have to have cost-benefit analysis, but he found, for example, a drop of about 25% in sick leave, workers' comp, and disability costs, and even bigger drops in workers' compensation. His total cost-benefit analysis, and by the way, this was based on 25 studies, adding together the savings from absenteeism reduction and medical care costs, it was closer than 6 to 1, which is really consistent with the separate numbers by Baker and Cutler. A really fascinating train of thought and series of research studies done by Jim Fries, where he has looked at the relationship between risk factors, simple risk factors, 3 of them: not smoking, being at recommended weights, and being physically active. He did this with a group of students from the University of Pennsylvania, and this particular study has been going since 1986. The students were followed since the early 60s when they were in school. And he looked at the relationship between practicing these behaviors and disability. Now, this is the year, and this is the age of the person. And what we see, not surprisingly, as people get older, their level of disability goes up. The red line is the people who smoke, who are overweight, and physically active. And they measure this at several points over this period. And it didn't really matter when that was true, whether it was when they were a student or as an adult. Same patterns existed. With the low-risk people, this is their rates. Now, what we see is the difference between the low-risk group and the high-risk group is a delay in disability of about 10 years, just by practicing those healthy lifestyle habits. So what's fascinating about this is if you think about maybe your parents. If you were able to delay disability, what impact would that have if you could delay it by 10 years on their quality of life and your quality of life? But from our perspective here, what's the impact on Social Security payments, on people going on to Medicare? And Jim is about to publish some new research that hasn't been published yet. With 60% of this cohort dead, what his previous studies have shown is he's been able to delay disability by 10 years. What this about to be published work shows that the death is delayed by only 3.5 years. And the reason that that is good is if people just lived a long, long time, it would make Social Security costs go up, Medicare costs go up. So that's not what we want. We actually want to compress disability, and indeed that seems to be happening. Compressing disability by an average of 6.5 years. So people are living just a little bit longer, but they're having a shorter period of disability. So that's the exciting new data. We'll hear about it soon. We'll read about it soon in the literature. So the caution here to policymakers, you've probably heard of the plans, the intentions to increase the retirement age. It's, you know, people don't like to hear that. It's really inevitable, unfortunately. But if we just increase the retirement age and people aren't any healthier, they won't be able to work, they won't be paying taxes. It'll just increase our costs for Social Security disability programs. So it's not going to do any good to increase the retirement age unless people are healthier. So some back of the spreadsheet calculations. If improving the health of the population can expand our working years of life by just 5 months, it'll reduce the federal deficit by 1.6%. If we can expand it by 4.5 years, it'll reduce the deficit by 16%. And by the way, you know, we saw that Jim's studies are pushing it back about 6.5 years. If we expand working years of life by 9 years, it'll reduce the federal deficit by 32%. So we're somewhere in the middle of these, maybe at the 25% level with Jim's work. Also, if we can reduce the annual rate of increase of Medicare by just 1/10 of a percentage point, it'll reduce the federal debt by 1.5%. If it can reduce the rate of increase of Medicare by 1 full percentage point, it'll reduce the federal debt by 15%. If we can reduce it by 2 percentage points, it'll reduce the federal deficit by 30%. Now, what we have found in industry, we've certainly been able to reduce the rate of increase of employer medical care costs by 1 percentage point and 2 percentage points. In fact, in some cases, we've reduced it by 6 percentage points. So these shouldn't be out of the realm of possibility. And oh yeah, if we also improve the well-being and quality of life for millions of people if we improve their health. So is my math right? I don't know. I'm not an economist. I'm pretty good with a spreadsheet. So we really need to do a lot more work on this. I also want to talk about what needs to happen to achieve this level of change. But what we have now is the beginning of a framework to answer those questions, Mari.
Well, Michael, this really is an interesting assessment of the situation. And it looks like we may be able to reduce the deficit by improving health, as you say, although you acknowledge that we may need health economists to critique and refine this hypothesis. So assuming that we improve health, assuming that improved health will preserve our fiscal solvency, what do we need to do to improve health?
Well, first of all, before I answer your question, I do want to really affirm we definitely need the help of health economists to really look in depth. The analysis I've done is really very superficial. It's not unreasonable, but we really need health economists to help us sort this through. But then focusing on your question, you know, if we do agree that improving health really is the best strategy to preserve our fiscal solvency, what do we need to do to improve the health of the nation? And the short answer is make the healthy choice the easiest choice throughout society. I think we have to do three things. We really, first of all, have to provide opportunities for the people who are most disadvantaged. And we should do this, of course, because it's the right thing to do. Everybody deserves an equal chance. But our pragmatic reason for doing it now is so that everybody can pay more taxes. I'm talking about low-income people having higher incomes so they can pay higher income taxes. Also, we do it because we want to reduce or eliminate Medicaid spending. We also want to reduce the diseases and costs that are linked to poverty and inequality. So until we do that, we're going to always have that rock holding us down. We also have to focus the missions of our federal departments, basically to say that health is important. I'll talk more about that in a moment. And then provide opportunities to enhance the health and well-being of the full population. And Mari, this is more what we think of in terms of classic health promotion. That's where I'll be spending most of my time this morning. I think in terms of addressing the needs of low-income people, I think we should look to what's already been done by Michael Marmot. He's led a team in the United Kingdom called the Fair Society and Healthy Lives Project. Published this in 2010, and it's the Institute of Health and Equality. And he basically says 6 things. Give every child the best start in life. Enable all children, young people, and adults to maximize their capabilities and have control over their lives. Create fair employment and good work for all. Ensure a healthy standard of living for all. Create and develop healthy and sustainable places and communities. Strengthen the role and impact of ill health prevention. So this is what we need to do to really raise the standard of living for the lowest income people. And I think we should build on Michael's work, Sir Michael Marmot's work, not try to redevelop those ideas. Now, focusing the mission of our federal departments. For example, in the Department of Agriculture, we could propose a new mission to supporting an agriculture industry that can provide the most nutritious foods to the greatest number of people at an affordable price. Our current focus is really maximizing agribusiness profits. And that made sense early in our history, but if health is important, we need to focus it in this way. In transportation, the mission could be to support transportation modes that move people and products efficiently, but do so in a way that enhances health through active transportation modes, facilitates social interaction and creation of a sense of community, and minimizes environmental toxins. We certainly want to improve the intellectual achievement of our youth, but also the physical, emotional, social, and spiritual health of the youth of our nation. So those are the 2 things that we really need to address before we get to the point of actually doing classic health promotion. And I think what we need to do in terms of the classic health promotion, Mari, is weave a web of support that reaches people several times a day, every single day, with the most effective strategies, not just where they work, and that's what we've been focusing on now, but also where they shop and study and worship and relax. And this is a graphic image of how this might work. We would have, for example, employers, 4 sources of funding. Employers, the Treasury of the United States, insurers, health insurers, CMS, the Medicaid providers, CMS, which supports Medicaid and Medicare, and the state Medicaid programs. They would all contribute funds to support this effort. Some of those funds would go right direct back to support their own efforts. But then funds would go to all the places that people are throughout their day. Some of the monies would actually go right to hospitals and clinics. And we also have to think about all the other factors in society that are going to have an impact. Now, when we talk about health promotion, what are we talking about? This is the definition of health promotion that I developed for American Journal of Health Promotion. The key point is we're not just talking about classic education. We're talking about comprehensive programs that enhance awareness, increase motivation, build skills, and most importantly, create opportunities that provide open access to environments that make healthy practices the easiest choice. So 4 major focuses: certainly awareness, motivation, skill building, supportive environments. Now, this is not what we're proposing, a government program. This is a private sector taking the lead, the state and federal governments doing their share. We see employers really supporting their employees at work. We see employers also supporting the families of their employees and doing so at home, in school, at college, in church, in the park, clubs, community organizations, basically wherever people are. we see health insurance companies reaching their customers at work, in the doctor's office, in school and college, wherever they are. And then we see Medicare and Medicaid really supporting the people that they support. And they'll do it at home, not just at the doctor's office, at church, in community organizations, wherever they are. So this wherever they are is really where the shift is different. Now, what's the budget for this program? It's $200 per person per year, which is the budget for a good health promotion program in the workplace. If we recognize there's about 310 million people, that's a budget of $62 billion a year. Now, how much is that? We estimate that the most recent analysis was by Robert Wood Johnson in 2005, and they published this in 2011 most recently. They estimate that we spend about $40 per person for all public health funding. This is all health promotion programs, but also all state and county and national public health programs. So it's 5 times more than we spend now. Although it might be a little bit higher, but probably not much higher than it was in 2005. Comparing to the size of our current workplace health promotion industry, it's 32 times higher, so significant increase. But compared to the liquid assets that companies have in their balance sheets, and this is just from the fourth quarter of 2011, there's $2.23 trillion in liquid assets among all the major corporations in the United States. So it's only 2.8% of that amount. It's also 2.1% of what we spend on medical care right now. So big increase from what we spent, but really small compared to what we spend in other areas or have available in other areas. So the other interesting news, Mari, is that the short-term benefits, which I'll talk about in a minute, may actually cover all the short-term costs in addition to reducing the federal deficit in the long term. Now, this shows how much is contributed by each of the different groups, most of it coming from employers. For the federal government, state government, it's just to cover their people, plus a little bit more from the federal government. And this is where the money might go. It might be $24 billion to workplaces, to schools, $10 billion, colleges, about $4 billion, child care, about $4 billion, hospitals and clinics, about $20 billion. So just an estimate of where this money might go, and I'll talk a little bit more about that in a minute. But to give you a sense of where these numbers come from, this is where people are. And so maybe there's about 20 million kids who are babies or in child care, about 54 million kids 5 to 17. Young adults, about 30 million of those, 20 million are in college. Working age adults, 165 million. Retired people, about 40 million people. Now, where do people receive their coverage? It's also an important factor. We have a total of about 120 million people who are working. This is about a year old. It's actually about 140 now. And then they have dependents. There's about 87 million dependents. So about 208 million people are connected either as employees or dependents through their employer. And then also there's about 58 million people on Medicaid, 40 on Medicare, and about 5 million through CHIP. So it's important to know what's our connection to people. So the interesting thing about this approach is that in addition to improving health, if the field really grows from about $2 billion to $62 billion, it's a $60 billion increase in revenues. And that produces, if we assume a little over a third of the total revenues are wages, that's $21 billion in new wages, which leads to 280,000 new health promotion jobs, assuming 75,000 per job. And that in turn produces $4.5 billion in new state personal income taxes and $22 billion in new federal income taxes. So, Mari, that's part of where the additional money comes from. Now, Is this a good point to break, Mari, for a little reflection?
Yeah, and I'd also like to encourage our audience to submit any questions that you might have. There's a lot of information that Michael's shared here that's just really fascinating and probably making our heads swim a little bit with all of these numbers. So if you do have any questions, please use the control panel on your screen to be able to enter any questions. So Michael, it sounds like you've really described a really interesting vision of how to create a culture of health in our country. And we can't argue with that. I think that's something as health promotion professionals we all desire. And you've also started to create a vision of new jobs that we could have in our field, which is also very exciting. As an entrepreneur, I'm thrilled to hear about that. You've thrown around a lot of numbers, told us where some of those numbers come from. So tell us, how do we, what role can we as health promotion professionals play in moving this forward, and how does this all become real?
Well, Mari, should I tell you a little bit more about the numbers? Just to make
Sure. Then, yeah, let's hear a little more on that.
Okay. So, where does this money come from? My thought is that most of it comes from employers who are self-insured. They would contribute about $27 billion for the 135 million people that are either employees or dependents, those numbers I just went through. Now, there are small businesses that have insurance, and just going back to these numbers I talked about here, their contribution would be about $4.9 billion. And this is for half of the cost of the programs they provide, because the insurance companies, small employers are not self-insured. So if there are savings from improving health, the savings go back to the health insurance companies. Now, there are also small employers who do not offer health insurance, and their contribution would be half of the cost of their 23 million employees and dependents. Again, because they're not receiving the savings from improved Medicare costs. In both cases, these employers are getting the benefits of enhanced productivity. Now, I see insurance companies contributing $4.9 billion, and it's really to share this cost here with the small employers who have health insurance. I see state governments covering the 58 million recipients. They're paying 39% of the cost, because that's the total percent of total Medicaid costs that state governments pay. It's $4.5 billion. The federal government contributes in several areas. They pay for half the cost of the small employers that don't have health insurance. They also pay for the people that they cover, the kids under the S-CHIP program and Medicare. And then they also pay 61% of the Medicaid costs. Again, the share ratio between the states and the federal government is 39 to the states and 61 for the costs. So their total contribution is the combination of these values. I think is about 16 billion. Now, why might this pay for itself? With employers who are self-insured, they can pay for it several ways. They can either add it to the existing health plan premium and have the employees end up sharing in the cost of this. The benefit ends up coming back to the employees in improved health and their own reduced health plan premiums. Of course, also the employers are the ones that they're the people who are the taxpayers of the nation who really want to save their nation. So that's one of the ways they can pay for it. Also, we've seen from several analyses that there's returns on investment of 3 to 1 for medical care costs and 3 to 1, almost 3 to 1 for absenteeism. And by the way, the absenteeism reductions usually occur by the second year. Medical care costs usually occur by the second or third year. So for the self-insured employers, the payoff is pretty clear. For the small employers, they don't get a payoff by reducing medical care costs because they're not self-insured, but they do see reduction in absenteeism, and also the insurance industry would cover half of their costs. For the small employers, reduced absenteeism with the federal government paying half the cost here. Now, the insurance companies they could pay for this in several ways. One, they could increase their health plan premiums in the short term. And if this is done by all insurance companies, that doesn't present any competitive disadvantages. So if they need to, they can just increase their premiums. But if they are reducing their expenditures, they're also going to see a reduction in medical care costs. So I think we can make a pretty convincing argument that the insurance industry would cover its costs. Now, for the state governments, they're going to have a spending of $4.532 billion. Their new tax revenues are $4.54 billion. There's an annual surplus of $7.8 million. And with the federal governments, their costs are $16.1 billion. Their new tax revenues are $22.5 billion. This is just the short term, Mari. So annual surplus of more than $6 billion. So, I would like economists to challenge my numbers. I'd like to have them rework the numbers, make sure I made the right analyses. Looking a little bit closer at this, and I won't go into too much of this detail, but it just shows the breakdowns. And this is a slide that's available for people on the website. It just shows where I got these numbers by detail. I won't go through them again. This is the breakdown of the source of fund by employers. It shows the when does the employer pay $200 per employee for the large insurers, and when do they pay the small? I won't go through those details again.
So Mike,
but I will say a little bit more. Yeah.
We've got a question from Kristen Erickson,
Yep.
and Kristen's asking, you're talking about the sources of the funding on this.
Right.
And her question is, who or what entity would administer this new vision?
Well, I'm glad that she brought that up, because the answer is I don't know. It could be a new industry. Like there's an insurance industry which collects money from employers, and then provides, negotiates with providers to provide medical care services. So it could be a new insurance type of industry that does this. It could be something that's done by existing insurance industry. They could just add this as something else that they collect revenues for, and they negotiate with providers. So that has to be determined. It could be an employer association. It could be something that, for example, there could be one entity for employers. There could be another entity for the federal piece. There could be another entity for the insurers. We have to figure that out. It's a new entity that needs to be created. And that entity, by the way, Mari, that could have the role of just collecting the money. It could also negotiate with all the different health promotion providers in all those different settings. It could actually maybe even provide services. It might have a regulatory function in terms of setting standards and monitoring standards and enforcing standards. So that's something that has to be determined. So very important question.
Good. And we've got another question from Judith Harris, and she's asking, how can we accomplish a prevention-based health system, or creating a culture of health in our economy, in a disease-based, insurance profiteering-based environment?
Well, that's the $64,000 question, Mari. And I'd like to come back to it after I just finish explaining a couple of these numbers, and then
Okay, let's take a look at a few more of them.
So the numbers, my assumptions were that for the new health promotion vendors, there was a profit margin of 10%, which gave them $6 billion in new profits. And then that's where the increase in corporate income tax came from. So they would be paying additional income taxes, corporate income taxes, as well as Social Security, Medicare, Medicaid, and individual income taxes. Also, in terms of, I also assumed that employers, by implementing comprehensive programs, they would also achieve a savings of $48 billion in their medical care costs. And assuming this is the effective corporate tax rates that employers pay, the average tax rates, that produces about $13 billion. And then this is just the additional funds from the federal government, which I talked about before. So with each, the main point is with each of my estimates, I did go on based on reasonable assumptions, based on the history that we see now and existing tax rates. So same thing with the same kind of breakdown for the state level. I also did want to make the point that something I'm not even including in these savings to state and federal governments. These governments have millions of employees. Local governments have 12 million employees. State governments have 4 million employees. Federal government has almost 3 million employees. They also have even more dependents. You know, altogether, they've got more than 30 million people. And if they have comprehensive health promotion programs for all their people, this should produce additional savings of more than $10 billion. And I was not counting those savings in any of my previous analyses. So, you know, Mary, this is also important. Where do we get this savings from Medicare? How do we figure that out? You know, Medicare, the assumption is with Medicare growth is that it will increase at 1.7% above inflation from 2012 through 2021. So then after 2022, there'll be no increase above inflation. Now, inflation is projected to be 2.5% for consumer goods. So just wanted to be clear about where those numbers came from. Also, in terms of the, how did I get the discount if we reduce 1%, where does that come from? If we assume a 2.7% discount rate, if we reduce the rate of increase by 1 percentage points, after just 15 years, actually, we reduce total Medicare spending by 32%. So my estimate of a 32% reduction in the total debt, it actually occurs right away. By the 16th year, we actually have reduction in costs of 48%. So these numbers add up very quickly. You know, I think it's a little too complicated to go through all the Social Security savings assumptions, but just want you to know that, you know, we did take a close look at that.
We'd like to make sure we have time for these questions. So could we go back to the question that Judith addressed?
Okay, that's actually part of what I'd like to talk about.
Okay.
Do you want me to say about the progress?
Sure, let's hear what's been done.
Yeah, so a couple good steps. First step, Mari told you, Health Promotion Advocates has adopted this issue as its core advocacy strategy. Also, for American Journal of Health Promotion Conference in 2013, we're going to devote an entire track, 8 sessions, on the science behind this. We've also had preliminary conversations with economists on how to do a better job of these analyses, as well as preliminary conversations with large employer groups, insurance trade groups, progressive think tanks, and congressional offices. So we're making some progress there. So this is really what gets to the question. We have to refine our program paradigm. You know, we have to shift from thinking about organizations, employers, to the network of organizations that make up a community. We have to refine our analytic models. And here's the key. You know, we've got to rally the support. You know, we the people, employers, the insurance industry, the Congressional, the CMS, the Congress, and the White House. And I don't know, Mari, is the answer to the question. And that's where we need input from lots of people. I think what we need to do is make everybody aware of the level of the crisis. And after we have really vetted these numbers, you know, when we're really confident that these are good estimates, show people how we can perhaps actually prevent the fiscal destruction of our nation by improving health. And I think the way that we do that is we involve all these different groups in helping to figure this out. We don't put a stake in the ground, and we don't say this is what will happen. We encourage everybody to look at these numbers closely and to use much more complex models to make projections. we also engage all the groups. You know, at this point, we've already reached out to the U.S. Chamber of Commerce and Blue Cross Blue Shield Association and AHIP, the America's Health Insurance Plans, and we ask them to help us think about the answers. We certainly reach out to our friends in the health promotion community and ask them how we go about this. So it's interestingly, you know, you did focus on the specific question of hospitals, you know, this disease-focused entity, and a lot of my background is actually in hospitals. It's where I got my graduate degree, and I spent my early years and recent years in hospitals. And what I found is that they are very much embracing this wellness model. In fact, the American Hospital Association last year, they released their strategic plan, and their #1 priority was to create a culture of health in hospitals. So I don't see resistance from the medical community on this, because they're confident. They can't grow fast enough, quite frankly. They can't hire nurses. They can't train nurses fast enough to fill staff positions in hospitals. We're projecting a shortage of primary care doctors of about 30%. So they actually don't see this as a risk to their financial success. You know, it continues to be one of the areas that's got the greatest growth. So I don't know the full answer, Mari. I don't expect resistance from the medical industry per se, but we have to involve all parties in helping to solve the problem. So back to you, Mari.
All right. Well, we've got a couple more questions, so let's take a moment to go through a couple of these. So we hear from Glenn Kent, who's in the food marketing industry. What role do you see me and my colleagues playing to help improve healthy eating and drinking habits?
Well, you know, that's a very interesting question, and it's interesting. I have found, and I've worked with a lot of the big food companies, they're basically agnostic. They will sell whatever people will buy. And the unfortunate reality is that so much of what the food industry sells now is really bad for you. It's full of sugar, it's full of fat, but ironically, it's what people buy. And I was fascinated. I worked on this project with the food industry, and each of them had significant money invested in strategies to create very healthy foods. And they're just waiting for the consumer to ask for them and sell them. So I would say to the food industry, be much more proactive here. I think that the food industry is at the stage right now that they'll soon be viewed the way that we view the tobacco industry, as villains that need to be stamped out. And it's because of all the very unhealthy foods that are sold. It really doesn't matter that people are buying those foods in terms of people's perceptions. So I would say to the food industry, be proactive. Take a lead in making something like this happen. It's really the opportunity to preserve the image as important, valued, respected corporate citizens, which I think will be lost within very few number of years if they don't take a more proactive approach.
That's great. Let's see if we can take a couple more questions here. So Kristen Erickson asks, who's going to train all of these new health promotion workers?
Well, all of our schools and universities have to do it. It's definitely a challenge. We couldn't meet this demand if it happened overnight. And I think it's not going to happen overnight. But absolutely very important. You know, we need to add this to the curriculum of schools of public health, exercise science, nutrition, nursing, medicine. You know, all the different areas involved in our field have to incorporate these ideas into their curriculum.
Excellent. And Holly Smith asks, where do the health exchanges fit into this picture, and when you have emerging public and private health exchanges?
You know, I don't know. I think it's an important question that has to be solved. Right now, for me, the exchanges are still kind of intangible. So it could be, you know, for example, that could be that question mark of the exchanges somehow collect the funds and point people to the right health promotion providers. But Mari, I really don't know the answer to that.
Well, there's probably a lot of questions that are going to come up as a result of all of this, and I'm sensitive to our time here. So in terms of the things that, that we here today can do, Michael, if you can just give us a couple of key points of, so these are great ideas, it's complicated, it's really big. What can we do, and where do we go next?
Well, I think you can help us refine this message. You can raise questions like everybody has raised. You know, where does it fit within the exchanges? You can help us in refining our economic models, in refining the program delivery strategy. How are we going to train these people, as somebody asked? You can spread the word. You know, engage partners. Employers are very important, health insurance companies, CMS, which is Centers for Medicaid, Medicare Services, Congress, White House, think tanks. I think the key thing that everybody can do is to spread the word and ask people to raise the questions that are critically important to answer to move this to the next level.
Excellent. Well, we're just coming up against running out of time here, so I just want to thank everybody for being here today, for your interest and attention on this important topic. We'd like to just ask you to send us some of your ideas, your reactions, your thoughts on how we can create a culture of health in this country and how we can achieve a goal of making America healthy with both our people and our economy by reducing the federal deficit and creating jobs in the field of health promotion by making the healthy choice the easiest choice. You can send your ideas to volunteers at healthpromotionadvocates.org. We'd like to remind you to, if you're not on our mailing list, to please go to our website at healthpromotionadvocates.org and join our mailing list so we can help keep you up to date on this topic. And we certainly welcome your input, thoughts, and suggestions on how we can move this forward to create a healthier country.
All right. Thanks, Mari. Thanks, Michael. I really appreciate you being here. Everyone, appreciate you too. Have a good weekend.